Okay, so good afternoon and welcome on this cold and frosty December afternoon to everyone. This is the Faculty of Clinical Informatics presentation by Dr. Rebecca Casey, who is from Newcastle University Business School, from Newcastle University, and Dave Wainwright, Professor Dave Wainwright from Newcastle Business School of Northumbria University. My name is Lawrence Brooks. I'm a Professor of Information Systems at the University of Sheffield, and I'm going to be chairing the session. And the session is called Towards a Democratic Approach to Realising Value and Benefits from Innovative Digital Technologies.
Let's start again. So if we just quickly introduce ourselves. Rebecca, do you want to go first?
Okay, thank you. So I'm Rebecca Casey, and as Lawrence says, I'm a lecturer and researcher here at Newcastle University Business School. I have been researching this topic for a number of years now, so historically and currently as well. I've been looking at benefits realisation, particularly in health and care settings.
Okay, and I'm a semi-retired academic based at Newcastle Business School at Northumbria University, and got around 30 years experience of education, especially in the information systems field. A large proportion of that looking at healthcare information systems, really from policy and strategy and also implementation perspectives. But I think, Rebecca, we've been working together about 8 years in total now. And latterly about 2 years, I suppose, or a bit more on this particular project.
Yeah.
Where we've done a bit of an update on previous work, which we'll expand upon in a minute. But can I just say, we'd like to make it fairly informal and discursive if possible. Not we try to avoid going into lecturing mode if possible. So.
Yeah, and also just to say that this is not intended to be, we're not intending to put forward an alternative approach, because we appreciate that methodologies already exist, particularly within the NHS. And really, this is intended to be a complement to the methodologies and approaches that already exist. But perhaps what we're suggesting is that we shift the focus towards a more democratic approach to realising value and benefits.
We'll expand on that in a short while in terms of taking a critical view of life, if you like, around these things, and our reasoning behind that, and also perhaps how that links to some academic theory, which again links to practice. So what we're calling this is a digital value playbook. We're trying to get away. This is our thinking, which we've talked about over the last year or more, Rebecca and I, that the word benefits has got a loaded connotation in many ways, in the sense that we have a negative view of benefits sometimes in society. But value is probably a little bit more symptomatic of the way that we want to place an emphasis on good things, positive things. So hence the idea of digital value as opposed to benefits. So we're trying to move away from the title benefits, which might upset some people, or in a traditional way. But if you stay with us, we'll explain that thinking as we go through.
Yeah. Okay, so here's just a quick overview of what we plan to go through today. We're going to start talking about some of the challenges and the reasons why we've come to this, looking at this area. A bit on our conceptualization of digital value realization, and also problem structuring. We'll have a little look at the playbook. It's quite extensive, and there will be a link to our website where you can look in more detail at some of the tools and techniques that we have on the website. We've just chosen a couple to look at this morning, and a couple of examples. And then we're going to look at summary and next steps. Okay, so just thinking about the background and challenges and where we've come to this. One of the projects that I was involved in more recently was with the PERTA Foundation, working with clinicians and professionals on the front line of health and care, and coming up with some marvellous innovations, really fantastic, and realising that perhaps they potentially might never see the light of day, and that's because for a lot of people there is they don't have access to that bidding infrastructure and procurement processes. which can constrain those innovations being and value being realized. So that was one of the kind of driving forces for looking at this. The complexities and computing requirements, so understanding all of the technical, the economic, the social, ethical, cultural.
Yeah. And go on and on.
Yeah, complexities and often competing requirements, where for some, clearly the priority is going to be around patient safety and quality of patient care. For others, an organisation, they're driven by delivering value for money, taxpayers' money. So it's, you know, how do you come to a point of accommodating some of these competing requirements? Also the legacy systems as well, which can be costly or difficult to integrate and replace. Involving the right people. So, and again, this is at every stage. So whether it's about setting strategy from the outset, who do we involve? And it's also about who do we involve when it comes to specifications, design, development, and ultimately deployment. Often, particularly in a health and care setting, people are too busy to be able to have the time to articulate what it is they need. So how do we kind of overcome that and make sure that we do have a focus and an emphasis on people's priorities and needs? And often we see, and we've particularly seen this during the pandemic, you know, an urgency to bring about transformation. But this can often be constrained by budget and budget cycles as well. So these are some of the key challenges, and feel free to comment on any others you think we may have overlooked. But those are the ones that we kind of see as key.
Just to top that up, that's looking at specific challenges. But personally, in terms of my academic career, I've been watching the NHS IT strategy for over 20 years. From early days of fund holding at GPs and the first introduction of IT into GP practices, right through to HIS, Hospital Information Systems, support systems, then NPFIT, and then beyond that into the Vanguards, etc. So I've always taken an interest watching how this unfolds and how the technology's developed over the years, and how perhaps we've always tried to create that value from this technology. We're better than we ever were before, don't get me wrong, we've been doing really well, but perhaps we haven't achieved what we thought we would 10 years ago. So hence the benefits realization and the value realization is still a very hot topic for everybody out there. So that's the angle we're coming at this.
And so some of you on this webinar may already be very familiar with benefits realization management, but we just thought it was worthwhile putting up here a quick definition on the kind of established methodologies. So John Ward and colleagues originally came up with this definition of benefits realization management, which they said was the process of organizing and managing such that the potential benefits arising from the use of information systems are actually realized. And they came up with this 5-stage cyclical model here, which you will see versions of on the NHS Digital website and NHS England website. Variations, not too different from this kind of original established model. And of course, the advantages of having a model such as this is that, well, we know that the failure rate of information systems and IT projects is stubbornly high. So having an approach is appealing to those dealing with the uncertainty and complexity and who are under pressure to deliver benefits from IT. It has the potential to be democratic. We would argue that it's not currently, could be more so. And this brings us on to the kind of cons associated with this model, which is that it does privilege the role of managers. And yeah.
Can I just add to that, just in the background? I think I was there in the early days of this. I'm that old, but John Ward, he was a IT director at Kodak originally, but this came with a lot of work from the States as well at that time, going back into perhaps the early 80s and the 70s. This was from the area of strategic information systems planning, which was all about business and IT alignment. So it was very much top-down strategic at that time. So this was never initially intended for healthcare. It was only latterly that they developed that work in a healthcare setting, specifically around examples to do with Choose and Book at the time, which they obviously got funding to do a research project with. So you can see the management bias of this, and the senior management and the chief execs and chief information officers was really pushing this idea of getting return on investment. So very much a financial reward from the investment that you make in the IT. So it comes from the hard commercial world, and it's only latterly, really, I suppose, in the last 10, 15 years, being pushed into the health service from that direction.
Mm-hmm. Yeah. Okay.
Right. So this is a sort of just some thoughts that we're coming up with thoughts all the time, Rebecca and I, about this particular area, and getting involved in practice as well as in theory. But in terms of when you look at outline business cases, if you look at typical ones that are out there, you can find them on the web, or people that you work with, and obviously people involved in this webinar are very much involved in the middle of all of this. But if you look at a typical foundation trust, let's say a trust not a million miles away with a Kerner Millennium System, an electronic patient record project, we could argue when we look at the benefits as they are laid out on the big spreadsheet that you get usually, they're really often a kind of vanilla wish list of things which come from a baseline from somewhere else, and then you add to that and you have your workshops, etc. But I guess what I'm truly playing a little bit of devil's advocate here and throwing them back is say, are they really just project objectives as opposed to really benefits or value or objectives? Do we really go in deeply enough to tear this apart? To say what really is value intrinsically, extrinsically, and what are objectives? What do we really mean by them, and benefits to who in terms of which stakeholders, and do we really get the right stakeholders on board often? We're often pushing this from a project management perspective, going back to Rebecca's point about the urgency of creating that business case and getting the procurement, the investment, and rolling that through and trying to justify all of that. So again, that goes back to that managerialist agenda. Not that we're not fighting against that, we're just trying to balance it up a little bit. I hate to use the word leveling up, but I'll throw it in, or level down in this instance, getting the bottom up perspective. So hence that's why we came up with how can we democratize digital transformation and translate the digital transformation that we require from the drivers that are coming top down from a policy initiative. They change all the time, as much as our politicians do. But the emphasis and how do we transform that into real value for the people on the ground, and not always never forget, and I'm a patient, Rebecca's a patient, and I'm sort of, quite a lot of experience of being a patient. The patient's views are not sometimes fully taken into account of a lot of these things. It really is orientated to other stakeholders primarily. So what we've come up with is really a complementary set of tools and methods and techniques, a knowledge portal, if you like, and that's what we're trying to develop, isn't it, Rebecca? Yeah. With this particular playbook idea, and for anybody to use, democratize it. It's not just project managers or benefits leads, but we hope that anybody can really get into this and use some of the techniques for their particular problem domain, or how to structure their problem, or how to get something, or how to understand the value that they might get from a project like an EPR or something like that. Yeah.
And to move away from just thinking about the financial value benefits, which is often what happens with these projects.
So
this is definitely
throw this one back at me, aren't you? For those of you who haven't heard of the man, it's one of my favourite modern philosophers. Is Jürgen Habermas, based at Frankfurt University. He's probably about 95 years old now. I think that's about how old he is. But he in the information systems academic world, this is being used an awful lot to try to understand how we can take what we call a critically informed approach to information systems, i.e. take account more of the human behaviours, and intersubjectivity goes on with sharing information and how we perceive that information. So this is just a simple depiction of some of his thinking, which is very complex, and I don't even understand most of it, to be honest. But it's quite useful because he splits up into 3 worlds. Basically saying that there is a material world out here, which we're fairly objective, and we have observation, we have facts, and that influences us, and we influence it effectively. And I know Lawrence, the chair of this session, is very much an expert on this particular area. But we also have our social world of intersubjectivity, where we work together, the sort of the organizational structures and cultures that we have. And then we have our personal world, which is our subjective experience. And all of these things have to be taken into account. If we're talking about stakeholders' benefits, we say, who's it benefiting and why, and what purpose is this all about? If we only take the material world, the technology that's going in, and hard facts and return on investment, we're only facilitating one aspect of this world that we're living in. And it's no wonder then that we don't really achieve what we're setting out to do, to make things fully transformative, or to make things work in all the ways that we want it to work. So we have to understand our social world of work, the organisation, and the management of change that goes around that. And we also have to know our personal world as well. So this might come in more into account once we do go towards looking at, say, looking at a modern manifestation of this, looking at healthcare apps and how we might use them for preventative health. We've got to look at the patient's subjectivity on this, and their worries and cultural aspects of that, as well as how you intersubjectively understand that. And we have an example around the COVID app, I think, which we'll do later, which was perhaps a bit of fun at the time, not fun for everybody else out there in the pandemic, but we just said, well, how would we depict the COVID-19 app in terms of benefits and a benefits approach, which we haven't actually seen published anywhere or anybody's actually done. So we'll show that in a second or two.
Okay, so just kind of summing up what we think established thinking says about benefits realisation, and particularly in relation to its application within healthcare. What we see is that existing studies, methodologies, approaches documented both in the academic literature, but also on NHS websites and other documents. They're predominantly positivist, so there's very much an emphasis on quantification, on measurement. They're quite prescriptive as well. Some of you may have been involved in, being required to do benefits reporting according to quite a prescriptive reporting methodology. And there have been few investigations into how everyday enactment can occur in terms of benefits and value realisation. Realising digital value has a patchy track record in health and care, and the National Programme for IT being probably the kind of most, I suppose, biggest example, of course, was one of the world's largest civilian IT projects, but just fewer than 1/3 of the forecast benefits were realised from that programme. The Department of Health is more emphatic now about expectations and outcomes arising from digital transformation, and that continues to shift in accordance with organisation and reorganisation about where the responsibility for that lies. You will all probably have experienced it can be centralised and then it can be localised again, and so I think we're going back into a more kind of localised approach. Digital funding in the NHS now usually mandates a process for realising value. Certainly the Global Digital Exemplar programme did. It's not clear whether the EPR programme of funding will mandate a process for realising value, but certainly the GDE programme did. Adoption of this national mandate is determined locally. That's increasingly what we're seeing. Sorry, that's Dave's phone going off. Apologies. And of course, what that means is then there can be confusion about, well, which approach should we follow? If there, is a centralized approach, then it moves to localized. How is that implemented? And what we found was actually there is a lack of capability training and development. So we surveyed acute trusts across the country, and found that the majority of trusts are at a more kind of basic level of maturity in terms of doing benefits realization, and that usually exists within that period of getting business cases over the investment hurdle, and perhaps a little bit of project management, but beyond that, there isn't the full life cycle approach that all of us may want to see. So I think what we're saying is that there needs to be more investment around training and development in this capability. So some of the definitions that we have adopted for our playbook. So stakeholder, we're saying that stakeholders can be individual or an organization or a consortium of organizations, and they are the people who are can affect or be affected by the objective, the activities and outcomes of a project. And realizing digital value, we've got quite a long I just have to move camera way there. So it's the process whereby the stakeholders are identifying, planning, and actualizing one or more things of worth to those stakeholders, and that could be through the use of new products, services or systems. And we go on to talk about, actually it's not straightforward value, it is complex and it's subjective and it is socially constructed. So I won't go into too much detail, but because Dave's already mentioned some of the ways in which we see value. Okay. So again, we're not going to go into detail with this, but this is our kind of life cycle approach that we see. So we've adapted John Ward's original 5-stage model and just put in some more specific steps. So we've just unpacked each of those 5 stages to describe some of the activities that you might engage in when you're going through each of these stages of the life cycle. So for example, there, stage 1, when it comes to identifying and defining those digital opportunities, we're talking here about using the playbook to understand what we mean by value, also the objectives that we're trying to achieve. And once we're clear about what those objectives are, then we can understand what kind of value can be realized if we achieve those objectives. Again, the ownership, really, really important. So understanding who will sponsor these initiatives, who will be the decision makers, and how we will engage users and developers and determine those accountabilities, how we are going to engage citizens and the public, politicians. And all of that work is to be done before you then go into developing a full business case, because what we often see is that business cases are probably developed at stage 1, before you are really clear about who all of the stakeholders are and where the lines of accountability lie. So we're suggesting that we could do a lot more work in terms of involving stakeholders before we get to a point of fleshing out a full business case. And this is just one of the tools that we have in the playbook, but this is just helping stakeholders to understand, well, what are our objectives. And I suppose we're used to kind of objectives being defined for us top down in an organization, but there's no reason why it can't be more democratic. And it's understanding across these 3 dimensions of, so, are we going to be closer to the patient, client? Are we thinking about health and care service innovation and leadership? Or are we focused on operational excellence? Or are we somewhere in between these dimensions? So you could be thinking about being as close to the patient as possible, but at the same time underpinning that with operational excellence and having, reusable IT platforms, for example, reusable processes and practices. So yeah, Dave, do you want to say anything about this?
What we've tried to do here with the playbook is bring in tools, techniques and methods from other areas of information systems, strategy and planning and implementation. So we've placed quite a big emphasis on the problem structuring phase. So often we think this is perhaps not enough emphasis or detail put on that with stakeholders. So using tools like this, you can obviously facilitate in a workshop, or you can do offline, come back with your thoughts in these particular areas. We're trying to widen it out so everybody can perhaps have a viewpoint from their stakeholder perspective. So not only using, this is a classic tool going back again many years, which initially was again for business and IT alignment in the days before Amazon, you know, when e-business and things like that were taken off, and we're thinking really about how digital technology would transform our lives. And well, it certainly has, hasn't it? But now translating it more into the context of healthcare and how we'd relabel these particular issues and start to work on how to expand upon the detail within these particular areas. So what you don't see here is another tool that we might use a lot of, which perhaps many people have come across, especially if they've done academic courses, MBAs and things like that, would be soft systems methodology, where we'd be, again, trying to look at a problem domain and problem structure in it, but bringing in a little bit more lateral thinking, open thinking in terms of what the problem actually might be and how we might go about producing solutions and actions around that. So our playbook, as it stands, we'll keep adding to it, really, has hooks and links to these particular techniques, etc., to go through and perhaps do this. We did mention the COVID-19.
Yeah, we did. So this tool here that you're seeing on the screen is it has a number of labels: benefits mapping, benefits dependency network. For me, I like to describe it as like a plan on a page. So if we read this from right to left, so starting with the purple circles on the right hand side, you start with the drivers. So like what's putting pressure on your service to review things and bring about some sort of change. So obviously with the COVID-19 app, there were a number of drivers, and Dave and I had identified these ones. So being motivated to capture health data, certainly initially that's what you know, those involved initially in its development of the app wanted to do, and they wanted to capture that health data at scale and at pace. We wanted to minimize the negative and economic effects of the pandemic. We also wanted to facilitate rapid epidemiological modeling and health data analytics. Of course, that changed over time, but certainly initially that's what they wanted from this app. And we wanted to curtail the rate of COVID-19 infections, reduce the R number, reduce hospitalizations, and ultimately reduce mortality. So you can see here, we've documented these as the kind of drivers and objectives, really. These were the objectives. And then moving across to the blue boxes. So this is our value. These are the benefits. And you can see here these benefits accrue to multiple stakeholders, so citizens. So the proof of testing allowed us, gave us freedom to travel, obviously within
boundaries.
Yeah, within boundaries, but that was part of the kind of value proposition, if you like, of the app. Public reassurance around health and well-being. It was also an opportunity to build communities and create a volunteer culture of us all coming together. We wanted to continue maintaining our economic output, work at home culture. There was also an opportunity for the UK to kind of demonstrate its capacity to innovate with technology and support the innovation in vaccine developments. There was the public health education, awareness and debate, and also we wanted to ultimately protect our health service and protect society and protect those vulnerable. So I'm not going to go through all of these, but we just wanted to show you just one of the tools that we can use and to really create very quickly a plan on a page that can be very useful for not only beginning to communicate what we think the objectives and benefits are around a particular initiative, but also then have that discussion and say, does this look right? What do we need to change? And then in the middle there, thinking about all of so if we are going to achieve these objectives and realize this value, what kind of changes need to be brought about as a result of that? What do we need to do differently? And those might be kind of new, very new permanent ways of behaving and working, or moving further across the map to the left-hand side, some of the kind of one-off enablers that need to be brought about to let this happen.
It's quite intriguing, actually, with hindsight, trying to map this out, because I think we're all trying to make sense of the COVID-19 app and then the NHS app and all these things that were suddenly happening, to connect them up. Because in terms of public information, we were only seeing snippets of these things and not understanding how on earth does all of this, with all the rest of it, cost £36 billion. And is it a success, or has it worked in some areas, not worked in others? I mean, a key thing with the COVID-19 app, which again, going back to basic organizational or our intersubjective world, was that, well, are people going to self-report that they've got COVID if their job's dependent on them being at work and earning money? And these issues seem to surface later on, not really thought through at the time, but appreciating the scale and pace of having to develop all of this with NHSX, NHS Digital, and syncing it with Android or iPhones. And all of this is a massive technological challenge you can see on the left-hand side, not least going into all the information sharing and ethical aspects of all of this. But we just kind of wondered at the end of the day, we don't know whether the people who were involved, massive teams involved in this project, were actually in their own way coming up with all of these areas. But has anybody actually connected it all together to give us a picture of why this is such a complex system? And have we, key thing here is, what learning do we take away from this for the next time? Because when a lot of people want to bury their heads in the sand and say there won't be a next time. But we should really be looking at this and saying, okay, this is how we did it, and how we might improve on that in the future. But it's like Rebecca says, it's a picture on the page, as it were.
Yes, and it's an opportunity to surface.
Sorry, Rebecca, Dave, I know you've got a lot to say, but just to let you know, you've got another 5 minutes if we're going to have some time for questions.
Right, okay. Thank you. Okay. So gosh, that's whizzed by, hasn't it? But I suppose we're just saying that using some of these tools surfaces some of these questions and challenges, hopefully much earlier on. So I was going to just talk briefly about a project I was involved in around telehealth, and now this is a picture taken from a clinical business change team in a hospital trust. So it's not mine, it's theirs, and they were implementing telehealth, and you can just see the box in the middle, benefits realised today. You can see around telehealth, they've documented there what they thought the benefits were that were realised from this project. And I just wanted to make a point that really these benefits documented here don't necessarily correlate with what the change team hoped to document, which was around patient experience, patient safety, and staff experience. You can see the benefits that ended up being documented and tracked were related mainly around cost savings. And again, the attribution and causality was problematic when I kind of questioned how this was done. It wasn't clear to me that they could isolate that one caused the other. So I just think we have to be really careful when we go down this sort of route, because what it does is it can undermine the whole practice of benefits realization, because people say, well, how on earth would you know that caused that? So actually focusing on some of the softer benefits can be more fruitful. And I just had some quotes here, because what that previous slide didn't uncover was around some of the challenges implementing telehealth. So when I interviewed the community matrons who had been given the responsibility to implement this, they were telling me, oh, well, actually, with this particular patient group, there were elderly patients with COPD. Many of them had problems with dexterity, eyesight. So being expected to use telehealth devices at home was quite problematic, and there wasn't necessarily the training available that there might have been. And also it was a project that was very target driven. There was an urgency about getting it implemented. So again, it came very top down. And you can see here the community matron here is saying that, it was quite stressful. They were, 30 patients were immediately put onto this program. then they were expected to kind of look through all of these results that were being remotely transmitted into a database without understanding the holistic view of the patient, and saying, well, actually, it didn't reduce visits, because we then had to go out and just check that everything was all right with some of these patients who we didn't necessarily know. And also talking about, for some patients who had this telehealth equipment, they became very reliant on those numbers and taking those readings. And here's a community matron just talking about a patient who wouldn't come off her oxygen because she was so fixated on these clinical readings. So it's just so important, the closer you can get to the patient, to understand some of the challenges and what can undermine our expectations, our benefits and value. That's really all I wanted to say about that. And so I think this is that we just see some of the issues around being political and agendas and interests of individuals and groups, both nationally and locally, and we all need to play a role in questioning that, and that actually sometimes power relations can be constructed through benefits realization practices, which can often be skewed to and privileged to a few, often managers, and then that then means there's a perception that actually this is the benefits realization becomes an instrument of change and a legitimizing device, rather than something that should be more democratized and inclusive. And that we're also saying that actually identified prioritized benefits up front, they're not inevitable, because benefits and risks are always contested and are always changing. So we need that life cycle view. And if we overlook those contesting views, it restricts the consideration of alternatives. So when I spoke to those community matrons, they had some fantastic ideas about how the telehealth would be better utilised for short-term assessment of, say, for example, diabetic patients who are changing treatments. So using it with that patient group. So they had some really good ideas about how it actually could be more beneficial and deliver more value. So it's just saying it's important to take on those, the contested views. I don't know if we've got time.
No, I don't think we've got time.
Do you want to? You've got another minute or so. Do you want to come to your conclusions and bring it together?
Yes. Yeah. So I think we're just saying, look, we need to take a broader view of the established thinking that we have documented already, so that we can shift the questions away from, those determinist approaches. And we've said it already several times about the need for democracy.
But I think in terms of the democratic approach, we need to put the tools and I was thinking it was more of a kind of an open source type of ethos, where we're putting the tools and techniques out there. It's not particularly dependent on a vendor and paying a license fee to a vendor or a consultancy. They're out there on the web, and people can get hold of them, perhaps with a bit of training or a bit of like webinar like today. You can go and actually use these things yourselves. But it will require some knowledge and education and training, perhaps, and some creative thought about how we get that down to practice. And then you've actually got to take action from that. And you can't just give these tools. You have to say, well, we are going to take notice and do something, about with the results.
Yeah.
So it's really then leading into a broader set of objectives. So
yes, we're not just thinking about financial return on investment.
No, I know, see in the playbook as well, it does go into tools and techniques for social return on investment. So it deals more with qualitative aspects, moving a little bit away from just purely seeing things in quantitative terms, because value is can be very soft, intangible, and difficult to measure. So yes, we'd like to observe it, but sometimes you cannot put a hard figure on things. You have to just understand that they are really valuable in certain ways and they're worth doing. So it's about supporting rather than mandating change. And we're not competing with anything that's out there. I have to reiterate that point. What we're doing is just providing more tools and techniques and knowledge, if you like, to share. Which can add as a complement to existing approaches.
Okay, thank you. So,
yeah.
If we're going to call it a halt there, because you said you did want it to be more interactive, so you have got some comments and a few questions in the chat, and then if people do want to ask questions directly, if they want to put their hands up, that would be great. So I'm just going to start with Lang Hamish, who pointed out gently that you were talking about one NHS, in England, and you might want to comment on this, not the NHS, and different approaches, not necessarily better in the devolved nations, might be kind of appropriate to consider. So were you just talking about the English, the English
Yes,
NHS?
I'm just talking about the English NHS, and we should have been more specific about that. I'm aware that in Wales, for example, they have their own approach to doing benefits realisation, which is a bit different. I'm not too sure about Scotland.
I know there are different different systems at play in Scotland and Northern Ireland. But I think most of our tools and techniques that we're talking about are generic and kind of be applied in context. So it wouldn't make a huge difference, in terms of why it's a different system in operation. It just might be that the political agenda's different and the context is different in that case. So yeah, I think it can be applied anywhere.
Okay, thank you. The next comment is from Joanne Adair about the Frontline Digitisation Programme. But I can see that Joanne's also got her hand up. So Joanne, did you want to ask this directly yourself?
Hi, yeah, it's just to say, so I'm a registered pharmacy technician and a clinical academic, but I'm now working on the Frontline Digitisation Programme as a benefits manager. You're absolutely right in identifying some of these challenges that you have, because what we are finding is that people don't think about benefits early enough in the process. So as part of our training, we're advocating things like problem statements and benefits mapping. But what I wanted to ask you was, obviously, in terms of frontline digitisation, it's a government major programme, so we're kind of restricted by the Green Book Guide and having to adhere to their methodology, and that does include societal benefits and quality benefits. But how much have you looked at the Green Book Guide, and does the playbook align with that?
Yes, we have looked at the Green Book Guide, and it does. I mean, what we're still lacking are some worked through examples on our website, which fully align. But certainly there is one example on the website around electronic nursing rostering, and which does I think we pull out two benefit categories, which we then go on to specify measures around. But I think we need some more examples, and actually what we would love to do is work with practitioners around providing some more work through examples on the website. But yes, so we are aware of the Green Book and being aligned with that.
Brilliant. And just to say, I know you referred to the GDE programme, so we have all the benefits data from the GDE programme, qualitative and quantitative, and we are using that now to support trusts with the FD programme.
Oh, fantastic.
Yeah,
that's great.
Okay, so we have you won't have seen it, but you've also got some of the participants kind of talking amongst themselves. So this is quite a long one. It started with Tim Benson talking about most digital innovations fail to achieve their aims, referring to Trish Greenow's paper in 2017, which identified 7 main types of failure in our NASSS framework, pointing out that any one can lead to failure. So NASSS is an acronym for non-adoption, abandonment, and failure to sustain, scale up, and spread of digital innovations. The 7 dimensions are conditions, technology, value propositions, adopters, organizations, the wider system, and adaptation over time. Tim says that he's found NASSS very helpful in identifying issues and whether you've got any comments on NASSS. But Tina Gallagher also agreed with Tim that it's very useful in a trust that just wanted to get digital for reasons other than those in the previous playbook slide. There are a third, she thinks, of English trusts that are not digitalized in any significant way, and there is a pressure to just become digitalized and then start working on defining, refining, realizing benefits. So the first thing was about NASSS and any comments on that, and second, I think, is about trusts that just want to get digitalized or get digital, and whether or not you've got any comments on how you can support them.
Yeah, I think with the first part of that, with Trish Greenhalgh's work on it would be the problem structuring phase, using tools and techniques to go into each of those elements to try and expand on that in the context of the particular problem set that's in that particular trust or whatever organization you're working with. So it would take time, and it takes some expertise in terms of facilitation to do that kind of thing. But you know, the democratic approach would be very applicable, because you'd want to take in people's views and not have a hierarchy there that would suppress those views. I think it should be very important to understand where failure could occur in any of those particular dimensions. What was the second part of the question again?
So there was from Tina Gallagher saying there are a third of English trusts that are not digitalised in any significant way, and there's a pressure to just become digital or digitalised, and then start work on defining, refining, realising benefits.
Yeah, well, you know, ideally you would say no, you should go through a proper process to try to go through the business dependency network and look at your drivers and work through from your benefits and value and what you're trying to achieve with that to link everything together. But I appreciate people having to achieve those targets, especially as the HIMSS maturity levels, trying to get to maybe level 5 or something like that very quickly, as with an electronic patient record, say. You've got to just get going as fast as you can, but take on board the benefits realization as you go. There's no easy answer to that one, to be honest, but I don't think you can avoid it, to be brutally honest. You wouldn't make that kind of commercial investment without going through this type of process, and it'd be mandated anyway, I would think.
Yeah.
So it's a question of how much resources you put into it and how much expertise you've got in you know, attached to the trust in terms of release of people's time, etc. These are thorny issues, but they have to be dealt with, and it's about really leadership and persuasion at the end of the day to fight for those resources to do it properly.
There was a bit of a follow-up question on retrospective benefits realisation measurement, and that it could well, the data shows that it could be quite good. Do you have any comments on that as well?
I mean, one of the issues about doing retrospective is that you therefore have an absence of baseline, you know, measurements or observations. So you've got, you know, you often don't have anything to compare it to if you're doing it retrospectively, compared with when you're setting out with a benefits value-led approach, where you would be taking a baseline. So that's one of the issues. And the other second issue with doing retrospective is that sometimes it can be, again, skewed, biased by wanting to publish a positive message about a particular initiative or project. So these are some of the issues about doing retrospective. No, but that's not to say it shouldn't be done.
Yeah. I think what this goes into as well is the issue of measurement, and how much emphasis you're putting on measurement as opposed to looking for improvement with measurement, but it's not all about measurement, if you know what I mean, and focusing on that. So retrospectively, what we'll look at is improving the system or troubleshooting to try to get that value from the system that's perhaps not being achieved. So yes, you as Rebecca says, you know, if you want to measure, you go get the baseline to see what improvements are being made, but you can also have perhaps objectives and targets that you're trying to achieve, or trying to redefine the value that you're getting out of the system, to try to produce workarounds and things like this, which you can do retrospectively once the system's actually implemented in operation. And technically, you know, there'll be debugging and all sorts of things going on, and upgrades and things like that. But often you find out the human side of things when you talk to people on the ground, say nurses or clinicians. Often they have their own workarounds around the system. And sometimes tools like process mapping can start to identify where in the flow of information or input or output or whatever that you can have a workaround that still is within the system, but it's slightly perhaps not what you originally intended, but it makes the system work and gets more value out of it. I know that's a bit of a fuzzy answer, but I think as a troubleshooting retrospective type of approach, it could be used.
Okay. We also have a question. You mentioned about complexity, and Bunch Anna asked a question about how do you take into consideration the complexity of impact on other projects on benefits or change in the environment and the need to change the benefit scope. So you'd mentioned about the complexity, and now it's about the complexity of other projects as well.
Yeah. Again, a lot of this comes down to just good communications, so this, the kind of the skills of those involved in managing and tracking the benefits and understanding the impact on other parts of a service or the organization. It's understanding this and talking to those people to understand and capture the impact rather than basing it on assumptions. So I think people involved in this work, there's just a need to be a good communicator.
Yeah, but it's also across an organizational boundary. I'll just give a simple example. It's involved in looking at the Better Care Initiative back in 2016 with Newcastle City Council, looking at integration of social care and health service trusts and primary care, secondary care and social care. But one of the things to come out of that, we were looking at telecare with, well, it was no secret, Your Homes, Newcastle, and also to GP practices who wanted to share information, but it was very difficult to share the information from a practice on patients that were prone to falls with social care or Your Homes Newcastle that who were providing the telecare service. So you'd have a heads up really of who in the community was prone to needing this type of technology. So one sort of set of value or benefits to come out of the GP system would be that analysis of that data of those people in the population that were prone to falls, and potentially sharing that across a boundary with social care or a housing community provider in terms of their program to install technology-enabled care or that type of technology. So one system, links to another system. The other systems are, talking to a GP recently. I've just mentioned that the NHS app, all I can see is booking information for appointments. I can actually go through that into the GP system to see my patient record. I could do that via my browser at home and going into that system, but I can't do it through the NHS app. And recent policy documents from government is all about the NHS app being a centre point for patients to get more services and a lot more value out of the information that's held about them on the system, and trying to cut down, hospital admissions and all the types of things that come from a lack of health and well-being. So systems don't link to each other. Still got a big integration problem, and the value from one set of systems to the value of another system, there will be leakage, but we can use the playbook and the tools there. If we went in specifically to look at that integration or interoperability issues and information sharing issues, we can perhaps then define that more carefully and do something about it. So that's the idea of the playbook, really, is put it into the hands of the right people to actually explore these issues.
Okay, we've just got a couple more minutes. And before we finish, I just want to remind people that Ruta has put a link in the chat window to ask attendees to complete a short feedback survey. So I'm sure the faculty will be very appreciative if you could complete that before you go, or maybe straight afterwards. We have another comment though from Tina Gallagher, which kind of follows up on some of the things you've been saying about communication. And Tina said that they found well-trained and supported change agents of whatever kind are invaluable in benefits realization, whether anticipated, unexpected, or retrospective. They're also a limited resource though, creating somewhat of a limitation, but a good resource nevertheless. So do you want to comment on the value of change agents and how they can help with this benefits realization?
In historical terms, it's always been about project champions, change agents. You go back to diffusion of innovation.
Digital champions.
Yeah,
But
it's
advocates.
yeah, advocates. Absolutely.
Yeah.
We don't put enough emphasis on
so important.
developing these people
Yeah.
and putting resources there for them to work effectively in organizations. It's always the latter end of an implementation. We talk about the training and management of change. Well, we talk about that right through obviously the project, but there could still be a lot more emphasis on this, I feel, and getting the right people to do that kind of work is very difficult with the effective knowledge in the background. I think with the playbook, we're just trying to provide some resource there for people. They can pick that up and they can use it.
Yeah.
But until perhaps we get more funding stream in to develop these people, I just go back to the old days. I used to work different university, but we had an old set of MBA programs for health managers where we would talk about these types of things, but that seems to have gone by the by. That sort of funding doesn't exist anymore. It'd be so nice if that kind of emphasis was put back into the system, because we really do need to put a lot more effort and energy into this. Perhaps.
And then finally, maybe you could just say where the playbook's going to go, what your future vision is, and also how it can get into the right hands, the people that kind of need to know about this.
Well, we welcome feedback from people. This is a work in progress. We're currently hoping to use it with an EPR project, but we would like to apply it to a lot more projects so we can have work through examples. We would like ultimately the website to be interactive and, hopefully eventually help people to develop those kind of business cases. But yeah, anyone who wants to help us with that, please get in touch.
We'll be looking for fun. We've developed this on a shoestring.
Yeah.
In terms of value for money, it's amazing.
Okay, thank you very much. Just to point out that the webinar has been accredited 1 CPD, Continuing Professional Development Point, and Ruti's put the email address in the chat, which is events@fci.org.uk. The webinar has been recorded and will be uploaded to the faculty website and the YouTube channel. And again, the links I think are going to be sent out to you. And they'll also post out any slides and a transcription of the question and answer session for download. If there are any questions, and there were just a couple that weren't answered in the session, then we will try our best to get back to you with a response after the webinar. And there are links to future webinars shown on the slide in front of you.